Нажимайте, да, нажимайте, я готов, да, да, да. Вы в эфире написано. Так, ага. Ну, давайте я сейчас... Вот. Я могу вот сейчас уже читать, да? Все, я тогда читаю, а вы ради интереса потом скажете, слышно меня там или нет. Спасибо, Саша. Uh, so primary infection demonstrates a more severe symptomatic picture. One-third of patients with primary infection report multiple painful vesicular eruptions of the vulva and perineum. In rare cases, a systemic flu-like illness develops in such patients. Rare forms of disseminated disease are associated with hepatitis, pneumonia, and even encephalitis. Non-primary infections with herpes simplex virus and recurrent infections due to reactivations of latent virus are associated with fewer systemic manifestations, fewer lesions, less pain, and shorter duration of viral shedding than primary infection. So the primary episode is much more severe than recurrent episode of infection. Most infants exposed to herpes during gestation appear healthy at birth. Sorry. Ага, да, Саша? Спасибо огромное, продолжу пока. Ага. Most infants, they appear healthy at birth. Findings of those who develop clinical disease may include fever or temperature instability, respiratory distress, lethargy, and poor feeding. Herpes infection can also rapidly lead to sepsis and even septic shock. The classic skin findings of vesicular lesions may be absent or may appear later. Let's talk about toxoplasmosis. This is infection, protozoal infection, Toxoplasma gondii is an obligate intracellular parasite. The infection produces a wide range of clinical syndromes in humans, land and sea mammals, and various bird species. It can be met in every country in the world except Antarctica. In many populations, such in El Salvador and in France, the seropositivity rate to Toxoplasma is as high as 70%. As many of 90% of adults in Paris, France, are seropositive. Approximately 50% of adult population in Germany is infected. Women of reproductive age in Western Europe, Africa, South and Central America have seroprevalence greater than 50%. So you see that toxoplasmosis is a worldwide common infection. Infects a large proportion of gross population. Individuals at risk for toxoplasmosis include fetuses, newborns, and immunologically impaired patients, such as HIV patients. Congenital toxoplasmosis usually has subclinical infection. Mothers with toxoplasmosis must be completely informed of the disease potential sequences to the fetuses. What is the clinical picture of acute toxoplasmosis? Approximately 90% of patients are asymptomatic, no symptoms, but symptomatic disease characterized by the following symptoms: cervical lymphadenopathy with non-tender nodes smaller than 3 centimeters in diameter, fever, malaise, night sweats, myalgias. Patients usually have sore throat. In some patients can be seen retroperitoneal and mesenteric lymphadenopathy with abdominal pain, ophthalmic problems like retinochoroiditis is reported, and immunocompromised patients. For example, AIDS patients may have seizures, cerebral signs, meningismus, movement disorders, and even neuropsychiatric disorders. Congenital toxoplasmosis is the most severe when maternal infections occurs early in pregnancy, before the 12 weeks of pregnancy. The earlier the worse. Approximately 55% of congenitally infected children do not have detectable specific antibodies at birth. Approximately 67% of patients have no signs or symptoms of infection. Ophthalmic problems is about 15% of patients, and intracranial calcifications develop in 10% of newborns. Those newborns may have anemia, thrombocytopenia, and jaundice. Microcephaly has been reported. Affected survivors may have mental retardation, seizures, visual defects, spasticity, hearing loss, and other neurologic sequelae. The prevalence of sensorineural hearing loss is as high as 28% in children who do not or who didn't receive treatment. So for the newborn, activation of toxoplasma is very bad condition. So we need to test patients before pregnancy for toxoplasmosis and during pregnancy. Suspected congenital infection in pregnant patients should be confirmed before administering treatment. What is the testing? Anti-toxoplasma immunoglobulin G, IgG, titers present a fourfold increase at peak 6-8 weeks following infection, primary infection, and then decline over the 2 next years, although they may still be remaining in the blood for a lifelong period. The presence of IgG indicates a likely past infection, while the presence of IgM usually indicates acute infection, like for many other infections and viruses. Lack of IgG and IgM usually exclude toxoplasmic infection. The specific test, which you can find in the literature, is a Sabin-Feldman dye test. It's a sensitive and specific neutralization test for toxoplasmosis. It is used to measure primarily IgG antibody and is a standard reference test for proving or excluding toxoplasma infection. Currently, the only effective vaccine against toxoplasmosis is Toxovax, which contains a live attenuated strain and controls congenital infection in sheep. No, unfortunately, vaccine for humans are available worldwide. Treatment is usually unnecessary in asymptomatic hosts, except in children younger than 5 years of age. Infant with confirmed congenital toxoplasmosis should be followed for evidence of development and neuropsychiatric development. And of course, ophthalmologic consultation is necessary because of chororetinitis. Treatment for non-pregnant patients, you can see on the screen. Usually we recommend pyrimethamine with a loading dose of 100 milligrams, plus sulfadiazine, plus folinic acid, leucovorin, and also trimethoprim and sulfamethoxazole, Bactrim or Biceptol usually can be used for treatment for non-pregnant patients for 4 weeks. Dosing and drugs for pregnant usually is spiromycin, 1 gram orally every 8 hours, so 3 times a day. If the amniotic fluid test positive for toxoplasma, 3 weeks of pyrimethamine and sulfadiazine is utilized, and plus pyrimethamine and leucovorin. What is important to prevent toxoplasmosis? So avoiding eating raw meat, unpasteurized milk, uncooked eggs, oysters, clamps, muscles, is the methods of preventing toxoplasma infection. Washing hands after touching raw meat, wearing gloves, washing fruits and vegetables. It's obviously the method of preventing, and avoiding contacts with excrements of cats. However, pregnant women and persons with HIV infection who have cats are at no increased risk for toxoplasmosis compared with persons who do not have cats. Rubella, a very common infection in pediatric practice, and sometimes it's seen during obstetrics patients, in obstetrical patients. Typically, rubella starts from the face or neck and goes down with suboccipital lymphadenopathy, arthralgias, fever, cough. So you need to remember and to know immunization history of your patients, probably rubella titers. You can see in the patient's chart. People in developing countries are often inadequately immunized, so you need to remember these things also. Also, up to 50% of infected patients are asymptomatic. 50%, congenital rubella syndrome in newborns are associated with 4 common forms of anomalies: deafness, 60–70% of fetuses, CNS abnormalities, eye defects, for example, cataracts, and even cardiac malformation. So, early rubella infection in pregnancy may cause very dramatic, severe disorders of the newborn in his or her later life. Deafness, cataracts, CNS problems, cardiac malformations. At birth, many infants with congenital rubella show evidence of growth restrictions and bone disease. Hepatosplenomegaly, also pregnant. Physical examination may reveal cataracts and congenital heart disease. Blood abnormalities like anemia and thrombocytopenia is seen often. Rubella virus infection in mother is confirmed by specific immunoglobulins M and G. Usually serum IgM level peaks 7–10 days after the onset of clinical illness and persists for several weeks before declining. IgG can be detected within 2–3 weeks of infection. Antibodies persist throughout life. PCR and viral culture or amniotic fluid has been used for prenatal diagnosis. Chorionic villus sampling, invasive prenatal diagnostics, chordocentesis can be used to test rubella antigen for PCR. However, chordosynthesis is difficult before 20 weeks gestation, and fetal immunoglobulins usually go undetected before the 3rd trimester. Measles. Measles is a very dangerous infection, quite common, can be prevented, and is associated with inadequate immunization, characterized by cough, coryza, and conjunctivitis. 3C: cough, coryza, and conjunctivitis. Koplik spots, which is shown on the photo, are pathognomonic for measles and appear as bluish-gray spots on the red base in the buccal mucosa, seen here. Rash begins several days prior to fever, so first rash and then fever, and spreads from head downward to cover most of the body. Measles. Parvovirus. Adults with parvovirus present with fever, arthralgias, and flu-like symptoms. However, 20–30% are asymptomatic. Clinician must ask about exposure to an infected child with parvovirus. Varicella-zoster virus. The incubation period of chickenpox, this is the virus which causes chickenpox, is 10-21 days. Primary infection is associated with maculopapular and vesicular rash, accompanied by constitutional symptoms that last for 3-5 days. Varicella pneumonia manifests even in pregnant women as a non-productive cough, dyspnea, fever, and pleuritis and pain, thoracic pain. Mothers with chickenpox infection may experience fever, malaise, myalgia prior to the onset of rash, which is vesicular rash, and may affect the face, trunk, oropharynx, and scalp. Adults are more prone to complications, including bacterial superinfections, pneumonitis, CNS abnormalities like Guillain-Barré syndrome. Manifestations in infants include multiple reddish pigmented areas and dermatoma. Most of these cases, if the mother was infected between 8 and 20 weeks of gestation, first and second trimester. Neonatal chickenpox infection that occurs when the mother has been infected within 2 weeks of delivery may manifest as fever and vesicular eruption. Some cases of herpes zoster have also been described in infants born to mothers who had varicella in pregnancy. A couple of words about Ebola, infection which is suspected in patients with recent travel to West Africa. Illness is characterized by common symptoms like fever, chills, myalgia, weakness, fatigue, and also gastrointestinal disturbances. Zika virus was quite common a couple of years ago in Latin America, probably in Africa. We didn't see it here in our country. Zika virus caused clinical manifestations in 20% of infected persons. Many pregnant patients had problems with their newborns, and of course symptoms of Zika virus appears 3-14 days after exposure and include low-grade fever, conjunctivitis, arthralgia, and maculopapular rash. Zika virus testing is recommended to all pregnant women with possible Zika virus exposure, even they are asymptomatic. The challenge of laboratory testing for Zika virus is that the window of time of Zika virus identification in blood and urine via PCR within the first 2 weeks of infection. In addition, testing can be difficult, particularly for patients who have reside in dengue-endemic areas, as there is cross-reactivity between Zika virus and other flaviviruses, especially dengue viruses. American College of OBGYN recommends combined Zika viruses, PCR, and IgM and plaque reduction neutralization test. Zika testing may also yield both false positive and false negative result, so exclusion of the infection is not always possible. Fetal ultrasonography can be used to diagnose growth restriction and may reveal specific associated with perinatal viral infection. Ultrasonography findings associated with cytomegalovirus infection include intracranial calcification, microcephaly of the baby, echogenic bowel, fetal growth restriction. Detailed fetal ultrasonography may be used to identify fetal injury associated with rubella syndrome and include intracranial calcification, hydrocephalus, microcephaly, and cardiac defects. In Zika virus patients, ultrasound may include microcephaly, ventricular megaly, and as well intracranial calcifications. So not much specific for different viruses. Amniocentesis or chorion sampling can assist in confirming specific infection detection. like rubella, CMV, B19 virus, Zika virus, possibly herpes virus. Amniocentesis for cytomegalovirus PCR can be performed after 20 weeks of gestation. Positive Zika virus PCR in amniotic fluid is diagnostic for fetal viral exposure. Treatment of such infections, such viruses usually include ganciclovir for CMV infection and acyclovir for maternal varicella infection. There is currently no specific treatment for Ebola infection. Treatment consists of supportive care, including hydration and correction of electrolytic disturbance and prevention of coagulopathy. Prompt isolation and infection control measures are paramount of importance. No treatment for maternal Zika virus infection. Supportive measures include acetaminophen, paracetamol for fever, and prevention of dehydration. Breastfeeding is not contraindicated in such patients, and no cases of transmission via breast milk is reported. If primary or recurrent herpes virus genital infection occur late in pregnancy, elective cesarean delivery is recommended, highly recommended, to prevent neonatal infection. If primary or recurrent herpes occurs just before the onset of labor. We need to educate our patients. It's important vaccination for some viruses and of course for prevention of many viruses and protozoal infection like toxoplasma, for example. Educating the pregnant patient to avoid contact with persons with varicella, washing hands can prevent infection. Varicella vaccine is available to anyone aged 12 months or older, a 2-dose regimen. Because this is live-attenuated virus, it's recommended that pregnancy be delayed for 3 months after administration. Pregnant women should be counseled regarding travel to active area of Zika transmission. Women and their partners who want to conceive should also be counseled regarding prevention and time lag prior attempting pregnancy or other partner is infected. A couple of words about coronavirus and pregnancy. We don't know exactly connection and sequela of coronavirus in pregnant women, but we understand that coronavirus pandemic is change our lives and our obstetrical life as well. You must know that it's caused by novel coronavirus, SARS-CoV-2, RNA virus, and the disease which is caused by coronavirus is COVID, which is acronym. Globally, more than 70 million cases worldwide. You see that United States is now in the first place, and India have almost 10 million infected. Russian Federation up to 3 million infected already, and other countries as well, high numbers of infected persons. Many countries developed national guidelines, and in Russian Federation we have here interim methodological recommendation version 9. For pregnant women, in the first trimester, it's recommended to use mesh nebulizers, salbutamol, 2.55 milligram by BID twice daily. In the second and third trimester of pregnancy and postpartum, use mesh nebulizers Ambrexol, 2-3 milliliters 3 times a day, plus bronchodilators, ipratorium bromide, plus phenaterol, Beradual, so-called, the brand name. Refer patients to ICU if respiratory rate more than 25 per minute and saturation drops less than 92%. We must remember that antiviral drugs can be contraindicated or non-investigated during pregnancy, so we don't know exactly the safety profile of such drugs for the newborn. Before 12 weeks of pregnancy, if moderate and severe cases of COVID-19, the termination of pregnancy is an option. Otherwise, chorion will sampling at 14-16 weeks to rule out fetal anomalies. At 20-23 weeks of pregnancy, emergency minor C-section for maternity reasons is recommended. It's according to Russian interim guidelines. After the 24 weeks of pregnancy, emergency C-section for both maternal and neonatal safety is considered. Normal spontaneous vaginal delivery is better, of course, and safer during active COVID-19 episode, patients with pneumonia. Regional anesthesia is safer than general anesthesia, but in severe cases, the caesarean section under the endotracheal narcosis should be done. During the second stage of labor, it's better to shorten the second stage of labor, to induce vacuum or forceps, obstetrical forceps, use antibacterial and antiviral therapy, respiratory support, desintoxication methods, bleeding prevention, because we know that coronavirus may cause some problems with coagulopathy. Keep lactation postpartumly until the condition of the woman will be stable. No delayed cord clamping is recommended in COVID-19 patients when in the delivery ward. No skin-to-skin contact with the infected mother. No breastfeeding in delivery ward. Transport baby to a separate neonatal ward. Of course, use protection, gloves, special masks, etc. It's necessary to take smears from baby's throat and nose for coronavirus. And any newborn who was delivered by infected mother should be suspected as infected baby. We can discharge home patients when a woman has a normothermia more than 3 days and no respiratory distress, and her lab tests are within normal limits, and no obstetrical and postpartum complication is seen. This is all for today. I hope the information was important and useful for you, and you take home my take-home messages that you need to remember that infections surround us in the real world, and our obstetrical patients as well. And those obstetrical patients, they're more susceptible to any infection, and avoid wishful thinking. You need to help such patients because they're usually immunosuppressed, because pregnancy is the condition where immune system a little bit slowed down, and you need to provide necessary treatment in case you suspect and proved specific infection. For example, like HIV, like toxoplasma and others. So thank you for today. I'm about to finish my presentation. Be healthy and study well. Have a nice day.